Others I'm going to discuss about the case history, which we encountered last week, and then about the definition of the severe acute malnutrition and the types of physiology, and one of the most commonest and commonest complication we see in syndrome, and its type of physiology and the principles of acute management. So moving on to the next slide, first I'm going to discuss about the case history. So there was a 3-year-old child, a boy, presented to the maternity ward with a history of lethargy and drowsiness for few hours. This is the second-born child, one consanguineous parent, with a birth history of birth weight of 2.32 kilograms via elective LSCS due to constipation. The first child being 9 years old and healthy, and the antenatal period was uneventful. The postnatal period, the CPU travel period, and the child was treated with phototherapy, with jaundice, and the IV antibiotics were given for 14 days. But the mother did not have any records with her on admission. At 9 months of age, the child was admitted to the professorial unit for the treatment of pneumonia. So there, on that admission, the multiple medical issues were encountered, but the parents had defaulted treatment. On admission, these were the examination findings. The child was severely wasted. The weight, length, and the weight for length all were below -3 st. The child was febrile, pale but not icteric. There was sunken eyes, absent tears, dry mucous membrane, no cervical lymphadenopathy. There was cold territories and the pulse rate was 126 with low volume pulse. And the capillary weakening time was 4 seconds. And the blood pressure was 45/30, which was below the 50th percentile for his age, sex, and height. The bilateral ARG was equal. There was no added sound. And the respiratory rate was 20 per minute. And the saturation was maintained 99% on normal. And the abdominal examination was unremarkable and no organomegaly. So at the end of the history and examination, we were able to identify following problems. The child was had dysmorphic facies, and even at the 9 months admission, they had queried about the Down syndrome, but no cardiothoracic was not done, and further investigations were not done. And the child had severe acute malnutrition and the global developmental delay. All the developmental domains were around 1 year of age. And there was a small period, the child had defaulted treatment at 1 year of age. And there was congenital subcapsular cataract where they had asked to do cataract surgery but also defaulted and the clot. So, and the management on admission we adopted as child with severe acute malnutrition who is presenting with shock. So, we put an IV cannula, we taken blood for the following investigation. For full blood count, for the identification of infection and underlying anemia and other pathologies, and CRP for the acute condition and the blood culture for identify of sepsis or any underlying infective focus, and the serum electrolytes and renal function test, liver function test, and DBG, UFR and urine filter and CPS. On admission, the CPS was low. It was 19 milligrams per deciliter. So here I summarize the things we have done at the ward. We gave oxygen via face mask. Even though child had good saturation, as they had low blood pressure and the drowsy, we put an oxygen via face mask. And then the child was hypoglycemic. So we gave 10% dextrose, 2 ml per kg, 10 milliliters according to the child's weight given. And then normal serum 20 ml per kg rapid bolus was given at the time. Then we started on maintenance with normal serum plus 5% dextrose, 20 cc per hour according to his weight. And then as empirical antibiotic, we started on IV ceftriaxone 50 mg per kg 6 hourly, and rest and PCR was done, and the monitoring was continued for the critical parameters on our hourly basis. And the capillary blood sugar also monitoring was done. So these were the investigation results we could have on the next day morning. The full blood count, the WBC count was 23,000 with neutrophil and leukocyte equal predominance with hemoglobin 10.3, small and low, but hematocrit was 30 with platelet being 142. Serum sodium was 134 and serum potassium was 5.1 and serum creatinine was 48, all three were normal and WDA was slightly elevated 86. AST was 2186, ALT 1115, both were elevated with alkaline phosphatase was also increased. Albumin was low at 1.8, total protein was low, but CRP was less than 2 and the total bilirubin and direct bilirubin also was normal. And apart from other investigation, the INR was 1.4, which was slightly elevated, and the VPG was it was acidotic, metabolic acidosis without any respiratory compensation was there. The pH was 7.163 with PCO2 39 and the bicarbonate was 14.2 with lactate being 4.4. After 8 hours of the admission, we found that the child had mean arterial pressure persistently below less than 40 meters mercury. So we started on no epinephrine thinking of sepsis. And then again, on the process, still the BP was persistently low, so we added adrenaline and we gave a whole blood of 10 mg over 2 hours duration. We continued monitoring 15 minutes interval and CBS was done available. And the input-output shot was started with NG insertion and we gave vitamin A or megadose 200,000 international units with folic acid dose of 5 mg. Also, zinc, the micronutrients, zinc was started given 2 per kg per day, dose, around 10 mg and around 10 hours we started on F75. So F75 is a feeding formula which we adapted to give in children who comes with severe acute malnutrition in short to avoid refeeding syndrome where I will give details in later on the presentation. So initially what we did was F75 gradually started 2-hour interval. Initially 50 kilocalories per kilogram per day and 75 kilocalories per kilogram per day, which gradually increased over 2 hours duration. And ultimately we continue 100 kilocalories kilogram per day F75 throughout the rest of the day, 2 hour basis. So this is the manager we adapted. At the end of the presentation, now I am going to explain about the definition and the pathophysiology of SAM, severe malnutrition and refeeding syndrome, and then comes to what we could have done better in this case. So these were the other investigations after 12 hours. The serum sodium was 104 and the potassium was drastically reduced to 1.7 from previous reading of normal 12 hours back. And the capillary blood sugar has shooted up to 400 milligrams per deciliter. So we have stopped at 75, but unfortunately after 24 hours, child passed away. So this is the definition. According to the WHO standards, the severe wasting and or bilateral edema, either of them, in children aged between 6 to 59 months, defined as severe acute malnutrition. So here the severe wasting is defined as extreme thinness, diagnosed by child where for length less than 2 years, length is taken in children who are below 2 years, and the height above 2 years up to 5 years, above 2 years, the below minus 3 of the WHO child growth standards. And also the severe wasting can be identified in mid-upper arm circumference, which is less than 115 millimeters, also taken as extreme thinness. So these were the two diagnoses. As we know, acute malnutrition divided into SAM and MAM. Today I am explaining about the SAM. So this is the classification as I mentioned earlier. The wasting, which is also called marasmus, having all the three features with reduced upper circumference arm and less than 11.5 centimeters, height below 380. If one of the either two is present, is taken as severe acute malnutrition. In the posterior part, the child can have they have edema, pitting edema, which is absent in wasting, pure wasting. So when now we come to the pathophysiology. First, starting with the cardiovascular system. In severe acute malnutrition, the body tries to preserve the energy, and so the physiological adaptation is there to reduce the energy expenditure on child's basal metabolic workout. So the cardiac myofibrils become thin with impaired contractility to conserve the energy. Also, the cardiac output also reduced proportionally to the weight. So, especially in marasmus, the cardiac output and the stroke volume reduce, and it is parallel to the loss of lean body mass. So, it is said that the cardiac index is usually normal in this case. Cardiac index is calculated according to the cardiac output divided by the body surface area. As the body surface area also reduces, the cardiac index is normal, but this is adapted up to certain level. Beyond this level, the cardiac output will reduce, the cardiac index will go low. So, the bradycardia and palpitation are common in the severely affected. This statement is very important to our case, and I will come to this statement later. And again, the bradycardia and the impaired cardiac contractility and associated electrolyte imbalances can predispose to arrhythmias in cardiovascular system. Also, there is intravascular volume depletion. So, the infusion of saline into management of the severe acute malnutrition can lead to increased venous pressure and cause acute heart failure. So, it has to be very careful when we giving IV fluids in severe acute malnutrition child. Then comes to the liver. The hepatomegaly from fatty liver is common, especially in kwashiorkor, because kwashiorkor is basically the protein energy malnutrition, where the marasmus is calorie and all the micronutrient deficiency is there. It's a calorie deficiency. So, in the severe acute malnutrition, the liver, all the peroxisome and the mitochondrial work is reduced, the metabolism is reduced. Therefore, more fatty acids are accumulated in the liver. Fatty acid oxidation is defected because of these mitochondria and the peroxisome defects, and also the protein synthesis also in kwashiorkor is reduced. In the hypoalbuminemia, therefore lipoprotein production also reduced. So they tend to accumulate more triglycerides and fatty acids in the liver and causing fatty liver. Also, conservation reduced hepatic gluconeogenesis occur, which leads to hypoglycemia. Also, reduced energy production from other substrates like galactose fructose also reduced. And again, all the synthetic function also affected. Albumin, transferrin, and all the transport proteins also reduced. And production of abnormal metabolites of amino acids also there, and it is less able to cope with the excess dietary protein and to excrete toxic and reduce hepatic metabolism. This reduced hepatic metabolism leads to all these complications. And when it comes to the gender uterine system, the glomerular filtration rate is reduced. The kidneys are less able to excrete sodium and water. Therefore, they accumulate and cause fluid overload. And also, they are more susceptible to urinary tract infections because of the reduced immunity. The gastrointestinal tract plays an important role. The environmental enteric dysfunction, also known as malnutrition enteropathy, affected all the functions of the gut from absorption, because it associated with villus atrophy, Cribb's hypoplasia, mucosal thinning, and it increased the permeability, and also there are lots of tight junctions. This main component of the gut barrier function. So the lymphocytic infiltration and gut dysbiosis. The bacteria malnutrition entropy. Also, there is gastric acid production also reduced, and also pancreatic exocrine function is affected. Therefore, it is almost universal in severe acute malnutrition, more seen in kwashiorkor. Therefore, sometimes glucose intolerance can also be there. So, the intestinal motility also reduced, which can be worsened by the potassium and magnesium reduction because of all the micronutrient deficiencies in this case. So, leading to IBS, paralytic IBS. And also the luminal gut dysbiosis, the bacterial overload, and the diminished gut barrier function can translocate bacteria and their toxins, lead to bacteremia and sepsis. So, they are more prone to sepsis and infection. Then comes to the immune system. So, the cellular immunity is reduced, as we know. If a child comes with malnourished child, is there, we know that their immunity system is activity is reduced because the main thing is the atrophy of the thymus, lymph nodes, and the tonsils. Especially reduce CD4 cells, rather than CD8 cells. CD4 cells are helper cells. They help to immunogenicity of other the blood cells. They are more stimulate other blood cells to make the immunity. But CD3, T helper cells, or what they do is they lyse the cells and cause cell death. So as the immunity is reduced with reduction of CD4 cells, they have loss of delayed hypersensitivity, impaired phagocytosis, and also reduced secreted immunoglobulin A production. Is marked in here. Also acute phase protein, but acute phase immune response is interactive this case. Usually they have inflammatory medias like interleukin 6 and CRP produced normally and particularly kwashiorkor. But typical signs of infection such as leukocytosis and fever may be absent in these kids. And also because of these symptoms, the child is susceptible to infective agents easily. Then the central nervous system. Reduction in the number of neurons, synapses, and dendritic arborizations and myelinators occurs because of the SAM, and this leads to cerebral atrophy, dilated ventricles, and periventricular white matter changes, which are obvious in the MRI, and also which leads to delayed global function, motor function, and memory. Especially neonates and infants are affected. The central nervous system affected in neonates and infants in SAM, even though they have a good plasticity of the brain. In the majority of patients, these loss changes resolve with treatment. Then comes the endocrine, the main three the hormones which increase with SAM are insulin, which leads to glucose intolerance. Also, thyroxine, insulin reduced because of the hypoglycemia energy reduction, and the thyroxine also reduced, usually T3 is reduced, and the IGF-1 also reduced. As it is a growth factor, but the growth hormone is increased to increase the to prevent the hypoglycemia. Also, the cortisol also is a stress hormone. As a child's body is in stress, cortisol also increase. Then comes to the respiratory system. The reduced thoracic muscle mass, decreased metabolic rate, and the electrolyte imbalances like hypokalemia and hypophosphatemia, which leads to decreased respiration, like minute ventilation. The tidal volume per minute, leading to impaired ventilator response to hypoxia. So even though there is hypoxia, they are unable to compensate with regard to the degree of hypoxemia because of that. And then comes the metabolism. The major metabolic rate is reduced and heat generation therefore impaired. So the children are more prone to hypothermia. In the other way around, they are more prone to hypothermia in very temperature environment. Then the cellular functions. The cell membrane, one of the basic components is sodium potassium pump, which is reduced activity of sodium potassium pump is there. Therefore, usually the sodium is potassium is taken into the cell, sodium is transported out of the cells. These pumps, therefore, these cells tend to increase sodium in the body and fluid retention. Also, put the potassium out of the cell, keep the potassium out of the cell. Also these membranes are leaky because of the SAM, and energy production also affected. Therefore, these extracellular potassium tend to leak from the kidneys. Therefore, hypokalemia also, in hypokalemia, they cannot compensate for the water retention. They are more prone to get water retention because of the hypokalemia. Also, the cell replication and repair also reduce and increase the risk of bacterial transportation to the gut mucosa. And again, the musculoskeletal system, loss of muscle protein is there. Therefore, all the micronutrients, potassium, magnesium, zinc, and copper also reduce because they are components of muscle. Then again, the skin and glands, which is important because the suddenly come up with the features of hydration. But these features can be shared due to other manifestation of the SAM. For example, the child's eyes may appear sunken because of loss of subcutaneous fat in the body. So it is a manifestation of dehydration as well. So you can take into account dehydration. Also the dryness of mouth, eyes and reduced sweat production because of atrophic sweat clearance and salivary glands can be there. And hematological wise, usually they have normocytic normochronic anemia, but sometimes other macronutrient deficiencies like iron, folate can lead to different blood pictures. And also the blood clotting is usually normal in these kids as this is a chronic, as it takes time, but the liver synthetic, acute synthetic function is intact. And as there is protein are reduced, they cannot produce more red blood cells, so the red blood cell mass is reduced, but the iron content is same because there is no proper way of excreting iron in the body. So this iron is accumulating. So usually this accumulated iron has to be converted to ferritin. So the conversion of the ferritin we use amino acids and glucose. So the ferritin is a protein. So, but in this child, all the macronutrients are deficient. Therefore, they are more prone to get hypoglycemia and amino acid imbalances. Also, the iron also free iron also accumulate. This free iron promotes pathogenic growth and formation of free radicals when they are free from the blood. The last side of the pathogenesis is particularly the macronutrient deficiency. They limit the ability to deactivate free radicals which cause cell damage. Also, all the other manifestations of the SAM like edema, hair and skin changes. So they consider refeeding. So as a summary, in severe malnutrition, what happens is to conservation of energy, the body is in the catabolic state. So the body try to preserve the energy. When we give feeding, the refeeding syndrome, what happens is when we give a sudden big feed, does this anabolic state suddenly transited, catabolic state suddenly transited anabolic state. So here I explain what happens in the refeeding syndrome. As I mentioned, in the catabolic state, the insulin is reduced because there is reduced glucose. They cannot form glycogen. So what they have to do is they need to increase the glycolysis, protein catabolism increase, energy production, and the gluconeogenesis is also increased. Vitamin and mineral nutrition levels also reduced in the starving phase. But when we introduce refeeding, usually this refeeding contains more carbohydrates. So the carbohydrate stimulates insulin production. So the insulin secretion suddenly increases. This insulin acts on cells which causes protein synthesis increase and glycogen synthesis also increase. Also they act on the cell membrane and cause the intercellular shift of phosphate, magnesium and potassium. This occurs very suddenly. Also they use kinase to cause carbohydrate metabolism, ultimately leading to hypophosphatemia, hypomagnesemia and hypokalemia because these cations go into the cells, and also thiamine deficiency and salt and water retention because with including potassium go inside the cells leading to hypokalemia and sodium go out of the cells because the extracellular sodium increase it causes water retention and expands the extracellular volume. So this is the things that I have mentioned. By the start of the nutrition therapy, carbohydrates are the main energy suppliers and concentration of glucose suddenly increase causing hypoglycemia. Therefore, the insulin secretion is there and intercellular shift of glucose and electrolytes. So the phosphatemia is very important in refeeding syndrome because the phosphate is the main substrate of the ATP, the energy production. So all the organs are affected when there is hypophosphatemia is there. And so as I mentioned, with regard to cardiac system, the hypotension and stroke volume reduced, respiration also, the contractility reduced because energy cannot be provided and all the systems are affected. And with regard to hypokalemia, as you know, they are more prone to get arrhythmias and rhabdomyolysis. And again, other respiratory gastrointestinal and symptoms. Those are the two main symptoms that we have to take care of with treating a child with severe acute malnutrition. Then again, hypomagnesemia leads to arrhythmia and also coexisting hypocalcemia. And also hypocalcemia features can be there as weakness, tremors, tetany and seizures in this case. Also the increased insulin secretion, as I mentioned, the sodium and water retention is there. They are more prone to peripheral edema and heart failure because of fluid overload. So the fluid overload, pulmonary edema and cardiac compromise are manifestations of feeding syndrome. And then again the thiamine. It is an important cofactor in the metabolism of carbohydrates, which allows for the energy production. And it enables the conversion of glucose to the ATP formation. So, in thiamine deficiency, what happens is glucose is cannot converted into ATP. So, these are converted into lactate. So, the lactate by the lactate dehydrogenase leading to metabolic acidosis. So, in thiamine deficiency, which leads to neurological manifestation as Wernicke encephalopathy, dry belly, also neuropathy, peripheral neuropathy, also cardiovascular disorders like wet belly. What happens is there's a cardiomyopathy and cardiac failure in wet belly, together with water retention. And thiamine deficiency, as I mentioned, and also there can be hyperglycemia and stress in repeating syndrome. So, the three main symptoms of repeating syndromes are tachycardia, tachypnea, and edema, but there are, as I mentioned earlier, many unspecific symptoms. So, when I come to our case history, I said that initially these were the findings. So, these are the learning points that we turned up. Initially, what we gave was a 2 ml per kg bolus. According to the guidelines, we could have given steroid 10% glucose, 5 ml per kg rapidly IV injection instead of 2 ml per kg, and given IV fluid 15 ml per kg over 1 hour. Prefer to use single lactate with 5% dextrose. And over 1 hour. Earlier we gave a rapid bolus because they are, as I mentioned before, they are more prone to get intravascular volume overload and heart failure. So slow bolus should have been given. And again, there were no signs of improvement. Assume septic shock, and we have to reduce the IV maintenance to 4 ml per kg per hour, which is mentioned in our guideline. So what we adopted was the full maintenance. So what is recommended is after giving a 15 ml per kg per bolus, we have to reassess the child. If the BP is going up, we can give another 15 ml per kg per bolus. In this case, child was still, there was no response. So we could have gone to maintenance until the blood is available. The next best thing was to give blood. After 1 hour, 15 ml per kg per hour. Blood is blood. If improving, we can give another bolus. If improving, we can give another bolus and start maintenance IV, and the next day morning after you start. And with regard to the antibiotic, what they recommend is gentamicin, 7.5 mg per kg per day, and ampicillin for gentamicin for 7 days and ampicillin for 2 days. And if the child is improving, we can shift that to the oral amoxicillin. So as and also as I mentioned, the 10 mg per kg fresh whole blood usually transfused slowly over 3 hours with the furosemide, 1 per kg at the beginning. So we gave over 2 hours, and also as the blood pressure was low, we didn't give a furosemide with the blood. And also we did serum electrolyte, repeated serum electrolyte 12 hours duration, but we could have monitored the serum potassium, sodium, calcium phosphate levels more frequently than 12 hours. 12 hours, there was difficulty in cannulation and taking blood in that case. There are multiple subjects to be there. And also the other thing was the child had mean arterial pressure persistently low, below 40. So this could be not due to septic shock, but sometimes because of the increased reduced contractility of the heart, and the in severe cases palpitation can be there. So in case, because with no adrenaline child's blood pressure didn't pick up at any point. So these were my references, and I took the WHO drug standard and the Nelson textbook and the protein energy malnutrition article and the repeat syndrome article by Good. And thanks.
Dan hypertension
Hypothermia, hypothermia, hypovolemia, and sensation related to từ lên lên từ 1 đến 10